the Electrical, Computer and Systems Engineering Department at Case Western University. He received his bachelor's from the Sharif University of Technology, Tehran, Iran, 96, MS and PhD degrees from the University of Michigan, Ann Arbor, 99 and 2005, respectively, all in electrical engineering. His main interests are in analog mixed signal, RF integrated bioelectronics, wireless power data transfer to biomedical implants, translational microfluidics, and microassays for point of care, point of injury diagnostics. He has published 2 book chapters, over 165 refereed publications, has 7 issued US and international patents. He currently serves as the editor-in-chief of the IEEE Transactions on Biomedical Circuits and Systems. He's inducted into the National Academy of Inventors in 2023 as a senior member for producing biomedical technologies that bring real-life impact on the welfare of society. Floor is yours, Professor.
Sure. Yes, thank you very much, Mehmet, for the kind introduction. I'm happy to be here to present our work conducted over the past 10 years or so on the clot chip technology for point-of-care assessment of hemostasis. For my talk, for my talk today, first I will just talk about the biological mechanisms that underlie the natural hemostasis process and provide a very brief overview of commercial point-of-care or POC devices on the market for the assessment of the hemostasis process. I will then focus on our own clot chip technology, a microfluidic dielectric blood coagulometer. I will talk about the sensor design, modeling, fabrication, and share with you our measurement results with the clot chip using in vitro modified human whole blood samples and the comparison of those results with those from existing clinical assays. I will also showcase our results with clot chip using real-world patient blood samples on anticoagulation therapy and also in hemophilia care management. Next, I will just briefly talk about the commercialization effort that we have embarked on for the clot chip technology over the past 7 or 8 years, and also share with you some results from field experiments using a commercial-ready portable handheld embodiment of the technology. And then finally, I will briefly talk about future outlook for our work before summarizing my talk. Please note that I'm a co-inventor of a portfolio of patents and patent applications on the clot chip technology that has been licensed by Case Western Reserve to a company called Exatech Incorporated. The company is actively basically aiming to commercialize our technology for 2 different market segments. And over the years, I've received both consulting fees, equity stake in the company, as well as research support from the company. So, hemostasis, basically, simply speaking, refers to the natural process of blood coagulation, the process by which blood in its liquid form basically remains within a blood vessel after vascular injury. If you have a vascular injury, for example, a simple cut to your fingertip, obviously blood wants to come out from the blood vessel at the site of the injury. In normal, basically healthy people, that's when the natural hemostatic process kicks in. And what happens next is actually quite fascinating. So first, tissue factor in smooth muscle cells, they get exposed to the bloodstream, and then they get basically binded to and then activate the coagulation factor 7 in the bloodstream. That itself basically activates coagulation factor 10, and ultimately this chain of reactions basically generates a small amount of thrombin, a procoagulant enzyme, also known as activated coagulation factor 2 in the bloodstream. Next, platelets, very important cellular components that typically reside in the plasma of blood in the resting state, basically home in on the site of the of the injury. They get, they adhere to the blood vessel wall at the site of the injury. They get exposed to collagen and von Willebrand factor that typically reside in the subendothelial matrix. Then the previously formed, thrombin in small amounts activates the resting platelets via the PAR1 receptor and basically induces a shape change in these active platelets. These active platelets subsequently basically aggregate with each other and form a platelet plug. These sort of processes involving adhesion, activation, and aggregation of the platelets is typically referred to as the primary phase of hemostasis. Next, these active platelets that have changed their shape, they express a phospholipid on their surfaces. This phospholipid in turn triggers a chain of enzymatic chemical reactions involving multiple coagulation factor proteins that ultimately results in a burst amplification of thrombin. And then thrombin next converts fibrinogen, a very important protein basically in the blood, in blood plasma, converts fibrinogen into individual fibrin monomers or fibrin strands that then polymerize and then cross-link with the help of activated coagulation factor 13 in order to sort of form the fibrin mesh as shown here. Next, the red blood cells, RBCs, and active platelets get enmeshed or get entrapped within the fibrin mesh. The active platelets exert a contractile force upon the fibrin mesh by just simply pulling and tugging basically on these, on the fibrin strands, and that gives rise to the clot retraction, which in turn basically results in further aggregation and deformation of red blood cells that have been entrapped within within the hemostatic clot or within the fibrin clot. As you will see later in this talk, these two processes involving aggregation and deformation of red blood cells are very critical basically for the nature of our sensing methodology. And also these sort of processes involving coagulation amplification, conversion of fibrinogen to fibrin, polymerization and cross-linking of the fibrin mesh is typically referred to as the secondary phase of hemostasis. Next, a tertiary phase of hemostasis kicks in, by which the injured endothelial cells release or secrete tissue plasminogen activator or TPA into the bloodstream. TPA converts plasminogen into plasmin, and plasmin, just like a scissor, basically it starts cleaving and cutting the fibrin mesh and basically results in the degradation of the fibrin mesh and the dissolution of the previously formed blood clots. This tertiary phase of hemostasis is referred to as fibrinolysis and is the process by which the previously the growth of the previously formed blood clot is controlled in order to sort of prevent the formation of thrombotic occlusions. Now, given the sheer complexity of what's involved in the natural hemostatic process, it should not be surprising that for patients who are on anticoagulation therapy, blood thinners, as well as those who are critically ill or severely injured, rapid, early, and accurate basically detection of coagulopathy or blood coagulation disorder that can give rise to a higher bleeding risk is quite vital, quite critical, because more often than not, it can be a matter of life or death basically for the patients. And now conventional laboratory tests, PT or APTT, are costly, are somewhat laborious, and provide only a snapshot of the coagulation process. These tests are primarily endpoint measurements and cannot really provide a temporal and dynamic assessment of the blood coagulation process. Moreover, these tests, PT, APTT, are plasma-based tests that are typically confined to central laboratories. There are commercial point-of-care devices out on the market. For example, one example of it is the Roche CoaguCheck XS, for point-of-care assessment of coagulation, basically outside of the confines of a central laboratory. But for the most part, these devices can be used only for specific patient populations. For example, Roche CoaguCheck XS device, is typically for use by patients on warfarin anticoagulation. More often than not, they sort of provide a variant of the PT and APTT parameters, obviously now in whole blood, just like their laboratory counterparts, they provide a crude assessment of the coagulation process, and perhaps more importantly, they cannot provide or do not provide any information whatsoever on the cellular contribution to hemostasis, for example, from platelets. Now, more recently, an old test called rotational thromboelastometry, or ROTEM, has gained much renewed interest in basically for cardiac surgery as well as in trauma care. As shown here, ROTEM is a patient-side viscoelastic blood coagulation assay. Typically, basically, as a kind of a benchtop, piece of equipment, as you can see here on the lower left side. What happens is that a pin is submerged into a cup that holds the whole blood sample. The pin and cup, they rotate against each other, and as the blood sample starts to coagulate, it provides a higher level of resistance to the movement and displacement of the pin. An optical sensor or detector from the outside measures the displacement of the pin, and then provides basically what I'm showing down here as the typical output profile for the ROTEM assay. ROTEM experiments are typically performed over 60 minutes, and again, as shown here, with readout parameters, 6 or 7 different readout parameters. Now they can provide a much more comprehensive, much more global assessment of the hemostatic process, unlike, for example, endpoint measurements such as PT or APTT. In this case, all those sort of readout parameters that correspond to the initial rising portion of the curve basically give information about the clotting or clot formation, and then all those readout parameters that kind of correspond to the declining portion of the curve basically give information, give insight about the clot lysis or clot dissolution processes. And again, as such, a ROTEM is generally considered a global hemostatic assay. However, because of the presence of, mechanical parts and moving parts, ROTEM is not easily miniaturized. It requires trained personnel. Each ROTEM equipment, including the reagent, costs typically about $50,000, and that primarily makes the equipment rarely available, if not unavailable, in low-resource community hospitals or in clinical laboratories where most blood coagulation tests are typically performed. Here you see kind of an overview, basically of some of the commercial point-of-care devices out on the market for coagulation monitoring. In a nutshell, some of these devices, such as CoaguCheck XS, iStat, or Hemocron, they provide information on coagulation function, but on nothing else. Verify Now or PFA 100-200, they basically provide information on platelet, but not, for example, on coagulation function or clot lysis. Only ROTEM and its cousin, TEG, thromboelastography, basically as viscoelastic hemostatic assays, basically can provide information on all different aspects of the coagulation and lytic process, again, as global hemostatic assays. The sample volume ranges from 10 to 20 microliters, quite conducive, to sample collection, basically using a finger prick process, all the way to hundreds and also maybe thousands of microliters. In this case, the sample now basically needs to be collected from a central vein, for example, using a venipuncture process. The detection technique runs the gamut from chemical to optical to viscoelastic, and the form factor of these devices, as you just saw, basically is either a portable sort of a handheld device, or basically a size of a bench, a small benchtop basically equipment similar to a printer, for example. Now, what we have tried to do over the past 10 years or so is to develop the clot chip technology. We envision a clot chip to be a portable handheld device using 10 to 20 microliters of human whole blood, basically as a global hemostatic assay, providing information on all different facets of hemostasis, coagulation function, platelets, and also the fibrinolytic system, using the so-called DS technique as the detection technique. Now, DS is the measurement of the complex dielectric permittivity of a sample under test over a wide range of frequencies. Basically, it quantifies for you how an externally applied electric field interacts with the dipole moment of the sample under test. Typically, molecules and cells in a liquid exhibit characteristic relaxation behavior that can be captured using basically DS measurements over a wide range of frequencies. For example, shown here on the upper right side, you see both the real and imaginary parts of the complex permittivity of ethanol and methanol measured over a wide frequency range of 1 megahertz all the way to 100 gigahertz. Now, it is known that if you can somehow perform these types of measurements, let's say in the so-called beta dispersion region that typically expands from hundreds of kilohertz to tens of megahertz, it is possible basically to extract and to obtain important and insightful information about the properties and characteristics of biomaterials, ranging from, for example, cells, including red blood cells, to various proteins. So what we have basically sort of set out to do is to sort of leverage the DS technique as a fully electronic, label-free, non-invasive or non-destructive sensing modality, and apply that to the problem of monitoring blood coagulation process, giving rise basically and giving rise to the technique of dielectric blood coagulometry. The way we do this is by developing the clot chip technology, in which the DS function is seamlessly integrated into a microfluidic channel. Clot chip is sort of envisioned to be a single-use reagent-free disposable cartridge requiring less than 10 microliters of whole blood for sample analysis. And certainly CMOS electronics can also be in the picture for sensor excitation and response readout to ultimately sort of provide the opportunity to create a portable, perhaps a handheld platform, as shown here in this cartoon, that can be used at the point of care, or generally speaking at the point of need. The clot chip technology right now for us basically features a three-dimensional capacitive sensing structure that has been embedded inside a microfluidic channel, as shown here. Two sensing electrodes and a floating electrode are basically embedded within the surfaces of biocompatible polymethyl methacrylate, or PMMA, plastic substrates. The PMMA cap can also be used for sample delivery, to the microfluidic channel. This structure can basically be modeled as basically a combination of two parallel plate capacitive elements, with the sample under test as the dielectric material, and then the floating electrode basically places these two capacitive elements in series with each other. Now, what happens is that when the sample under test, in our case basically a blood sample, is introduced into the microchannel, basically basically in the three-dimensional capacitive sensing area defined by the overlap of the sensing and floating electrodes, the impedance of the sensor seen from the perspective of the two sensing electrodes changes based on the dielectric permittivity of the sample under test. That equation, is shown here, and then basically a simple rearrangement of the terms basically can show that the real part of sensor measured sample permittivity is proportional to the imaginary part of sensor admittance, and vice versa. The imaginary part of sensor measured sample permittivity is proportional to the real part of sensor admittance. In this case, omega is the operation frequency, and C0 is a frequency dependent factor, basically sort of capturing the nominal air gap capacitance of the sensor that typically can be obtained using a one-time calibration procedure. Now we currently employ a simple, low-cost, laminar batch fabrication, technique for fabricating these clutch chip sensors, as shown here. Two sensing electrodes and a floating electrode basically are deposited, either via printing or more recently for us via gold sputtering on the inner surfaces of two PMMA plastic substrates. We also have a laser micromachine, a double-sided adhesive film or DSA film, basically in which the microfluidic channel is cut out basically with laser micromachining, and then using some alignment holes and pins, we manually align and then affix the PMMA cap to the PMMA substrate with the DSA film sandwiched in between. So the total height of the microfluidic channel is this, or the separation or distance between the sensing electrodes and the floating electrode, is set by the thickness of the DSA film, in our case about 250 microns. In one fully assembled clutch chip sensor, the total volume of the microfluidic channel is just under 10 microliters. Here you see some, our first measurements basically of human whole blood using the clutch chip microsensor that has been interfaced with an impedance analyzer, measurements being performed at a frequency range of 10 kilohertz all the way to 100 megahertz. The real part of dielectric permittivity of blood is shown here, basically for the for whole blood in the blue curve, and then for blood plasma in the dashed gray curve. We can clearly see the presence of a dispersion region in the blue curve in the megahertz frequency range that arises from the interfacial polarization of red blood cell membranes within the conductive surrounding plasma, and then perhaps more importantly, the lack of this dispersion region in the blood plasma measurement, given that plasma basically is devoid of any red blood cells. We have defined the output curve of the clutch chip sensor as shown here as the temporal measurement of the normalized real part of the permittivity of human whole blood, measured at a frequency of 1 megahertz and temperature of 37 degrees Celsius. We typically conduct basically our clutch chip measurements as shown here over maximum 30 minutes. Right now, for use in the lab, we typically obtain our blood samples in collection tubes that already have sodium citrate anticoagulant basically embedded into the collection tube. So right before performing experiments, we introduce calcium chloride into the whole blood sample in order to basically induce and initiate coagulation of the sample. Now, what we have sort of observed consistently over the years is that for a calcium chloride treated sample that ultimately starts to coagulate inside the microfluidic channel, we consistently see this sort of these features of rise in the permittivity to a peak level at a time corresponding to what we call T peak, followed by the fall or decline in the permittivity, and then ultimately a plateauing or leveling off of the tail end of the curve by the time we get to the end of the measurement period. Whereas for a citrated sample that does not have calcium chloride added to it and therefore does not basically really have any mechanism for coagulation, these features of rise, peak, and fall are never present. And basically the as shown here in the black curve, the permittivity just keeps rising monotonically basically until we end the experiment. So so far we have sort of we have identified T peak as our first basically readout parameter that can be extracted from the clot chip readout curve. We have also as shown here, identified at least the second readout parameter. We call it delta epsilon max from the same clot chip readout curve. And this basically quantifies maximum change in permittivity after T peak has reached. And now next, in order, for us to understand what type of important, biological properties on the blood sample these readout parameters provide, what kind of insight or information these parameters provide to us, we basically formed some hypotheses and ran many experiments in order to sort of ascertain the veracity of those hypotheses. For the T-peak parameter, we hypothesized that T-peak parameter is basically a measure or a surrogate for coagulation time of the blood sample. Or more precisely, the time that it takes for the onset of fibrin clot formation. We also hypothesized that the second readout parameter, delta epsilon max parameter, is ultimately a measure or indicative of the stability and firmness of the fibrin clot, basically sort of reflecting on the interactions between cellular components such as platelets and red blood cells and the fibrin mesh. Focusing first on the T-peak parameter, we performed experiments, by in vitro treatment or modification of whole blood samples with both thrombin and thrombin inhibitor. If you remember from my very first slide, thrombin is a procoagulant enzyme, activated coagulation factor 2, and basically is expected to hasten or speed up basically coagulation time, whereas thrombin inhibitor would normally have an anticoagulant effect, basically resulting in a prolongation of the clotting time. Shown here on the left-hand side is basically sort of typical curves coming from the clot chip. The curve in blue is basically, for a normal, healthy, untreated human whole blood sample, in this case, giving us a T-peak value of about 5 or 6 minutes. And then basically the black curve in which the same blood sample has been treated with thrombin. There's a clear shift of T-peak basically to the left, a shortening of T-peak corresponding to an acceleration of clotting kinetics, and then vice versa. For the red curve, basically in which the blood sample has been treated with thrombin inhibitor, there's a prolongation of clotting time and therefore a corresponding shift of T-peak to the right. The corresponding parameter in the ROTEM assay is called clotting time or CT parameter as shown here. This basically is the time instance at which the amplitude of the ROTEM profile reaches a level of 2 millimeters. And just like the clot chip assay, basically the same behavior basically is exhibited by the clotting time CT parameter, basically shortening of CT for thrombin inhibited sample and then a prolongation of the CT for the thrombin inhibitor treated sample as compared to the blue curve representing normal untreated blood sample. In fact, there is a very strong positive correlation between the clot chip T-peak parameter and the ROTEM CT parameter across 9 different blood samples that we had tested. Next, we recruited 27 subjects into a simple paraclinical study. 15 of these subjects were normal, healthy volunteers and donors with no known issues, basically with blood coagulation. All 15 basically curves coming from the clot chip sensor or assay are shown here, superimposed on top of each other. The normal reference range of T-peak, at least for these 15 patients, was basically ranging from 4 minutes to 8.5 minutes. Then the remaining or the other 12 subjects were actually patients suffering from various hemostatic defects ranging from hemophilia A, in which the coagulation factor 8 is missing or abnormally low, hemophilia B, in which coagulation factor 9 is missing or abnormally low, von Willebrand disease type 2B, basically a rare disease in which basically the patient has problems with von Willebrand factor protein in the blood. The point is that basically all these patients basically manifest a prolongation of the coagulation time or the clotting time in the blood sample, as shown here by a corresponding shift of the T peak to the right, as compared to, for example, what we see here for the black curve, basically representing a normal, healthy blood sample. In fact, we sort of ascertained that the prolongation of the T peak in the coagulopathy cohort was in fact significant as compared to the healthy cohort with a p-value less than 1/10,000, signifying that the clot shaped T peak parameter can be sensitive to coagulation defects. And next, we sort of wanted to focus on the second readout parameter, the delta epsilon max parameter, and sort of assess how abnormalities first in red blood cells and then in platelets basically can potentially affect that second readout parameter. In this case, we performed experiments in which we performed in vitro modification or in vitro treatment of red blood cells with a reagent that artificially basically stiffens their membranes. These, these rigid or membrane stiffened red blood cells can sort of, can sort of mimic, for example, what happens pathologically speaking in a red cell disorder such as sickle cell disease. For a given level of fibrin clot formation, fibrin clot retraction force being exerted upon these red blood cells, as you can imagine, these rigid membrane stiffened RBCs would basically sort of undergo a much less level of shape change because they are very poorly deformable. As shown here, for example, in red on the left-hand side, these sort of membrane stiffened RBCs, as expected, largely retain the biconcave disc-like shape, whereas, for example, shown in the blue on the right-hand side, basically untreated normal RBCs can basically experience significant shape change basically once they get entrapped within the fibrin mesh. Now what happens is that we sort of observe that this ultimately shows itself in the second readout parameter of the clot shape curve, as shown here. Basically there's a corresponding decrease or reduction in the delta epsilon max parameter with the presence of membrane stiffened RBCs in the blood sample. In fact, more interestingly, this reduction in the delta epsilon max parameter, is shown to be almost dose dependent, basically based on the percentage of membrane stiffened RBCs and they reconstitute the whole blood. So, in this case, for example, going from the cyan curve, 20% stiff RBCs, to the green curve, 50% stiffened RBCs, all the way to the red curve, 100% stiffened RBCs, as compared to 0%, at 0% membrane stiffened RBCs, significant reduction basically in the delta epsilon max parameter. Next, we kind of wanted to see how platelet inhibition can potentially, affect this second readout parameter. Perform similar experiments to the T-peak basically experiment, but in this case, we used cytocalazine D or Cy-D as our reagent for in vitro modification of human whole blood samples. Cytocalazine D is basically a reagent that inhibits platelet function by preventing basically active platelets to undergo shape change. As a result, these active platelets that cannot undergo shape change end up sort of not being able to exert a high enough force basically on the fibrin mesh, and therefore basically the sort of, the clot retraction is not as strong as compared to a normal, basically healthy case. And again, in this case, in different cases involving different concentrations of the Cy-D, so in this case, higher concentrations concentrations of SID basically correspond to higher levels of inhibition of the platelet function. And basically, once again, we can kind of see a dose-dependent decrease in the delta epsilon max parameter of the clot chip. The corresponding parameter in ROTEM is called MCF, maximum clot firmness. And again, once again, similar to the clot chip case, basically a dose-dependent decrease in the MCF parameter for higher levels of SID corresponding to higher levels of inhibition of the platelet function. And once again, the clot chip delta epsilon max parameter, the second basically parameter, also shows a positive strong correlation to the ROTEM MCF parameter across 13 different samples that we had tested. We also, recruited 10 healthy volunteers into a, second pilot clinical study, but this time we used aspirin, basically in order to spike the blood samples with aspirin. As you, probably know, aspirin is another type of antiplatelet drug or medication, but it works differently than SID. Aspirin basically ultimately makes the platelets less sticky. It kind of interferes with the aggregation, basically, of the platelet, but again, as expected, basically there's a dose-dependent decrease in the delta epsilon max parameter, for higher levels of aspirin concentration that was spiked basically into the blood sample. So far we sort of established that at least two different readout parameters of the clot chip of the clot chip curve can sort of provide information or have sensitivity to either coagulation functions or basically deficits in platelets. Next, we kind of wanted to see whether we can identify perhaps additional readout parameters from the clot chip readout curve that can give information about the fibrinolytic system. In this case, we sort of repeated the same mode of operation, basically in vitro treatment of human whole blood samples, but this time the reagent was tissue plasminogen activator, or TPA. If you remember, again, from my first slide, TPA basically converts plasminogen to plasmin and ultimately sort of induces an upregulation of fibrinolysis. Shown here on top, we can see the clot chip readout curve that is obtained in the case of a TPA treated human whole blood sample. At first we can kind of see the same features that we were seeing before: a rise in permittivity, a peak, followed basically by a fall or decline in the permittivity. But unlike previous cases where the tail end would ultimately sort of plateau or level off by the end of the experiment, we do not see that type of behavior anymore. There's a clear inflection point on the tail end of the clot chip readout curve, followed by basically a monotonic rise in the permittivity. The plot shown down here is just simply the first order time derivative, basically of the upper plot, and clearly showing the presence of that inflection point on the tail end of the clot chip readout curve. And then based on the presence of this inflection point, we sort of ended up defining or identifying two additional readout parameters in the clot chip curve as shown here, LT and MLR. LT, or lysis time, measured with respect to T-peak. We hypothesized that this is the time that it takes from the onset of clot formation for the fibrin clot to mostly dissolve and basically disappear in the blood sample, and the amplitude of that inflection point, or maximum lysis rate, MLR, simply captures the rate of fibrin clot lysis. In order to sort of perhaps further ascertain this, we sort of use now different concentrations of TPA, 250 nanogram per ml, 350 nanogram per ml, all the way to 700 nanogram per ml. And again, as shown here, going from basically from the case of 250, the green curve, to the case of 350, the black curve, all the way to the blue curve, basically, a dose-dependent decrease in the lysis time parameter and dose-dependent increase in the MLR parameter, with higher concentrations of TPA basically being used to in vitro modify the blood sample. as now, at this point, basically, you can perhaps, realize that the same, or, equivalent output parameters also exist in the ROTEM assay. The lysis time actually is called for ROTEM as well. Time measured from CT until clot firmness is decreased to 10% of the maximum level, and then clot lysis rate, or CLR, is measured in degrees, is the angle between the baseline and a line, a tangent to the declining portion of the curve. And again, as expected, these two parameters in the ROTEM also show a dose-dependent, basically sort of trend or behavior with higher concentrations of TPA. A lysis time of clot shift similar to the TP parameter shows a very strong positive correlation to the lysis time parameter of ROTEM, and the MLR parameter of clot shift also shows a strong correlation to the CLR parameter of ROTEM across 9 different samples. Now, so far, as you perhaps noted, we have done lots of experiments, with the microsensor, clot shift microsensor, but using in vitro modified or in vitro treated human whole blood samples. Next, we kind of wanted to see what happens or how clot shift behaves with real world, patient clinical samples. We did this in 2 different contexts. First, in the context of monitoring anticoagulation therapy. So very briefly, patients who are basically, suffering from various cardiovascular complications such as AFib or, or venous thromboembolism, VTE, generally need to be chronically on anticoagulation therapy, basically blood thinners. Now, for the past half century, warfarin has been the anticoagulant of choice, but over the past 10 or 15 years, a new class of anticoagulants called direct oral anticoagulants, or DOACs, have come on the market, have been FDA approved, that have sort of rapidly replaced warfarin as anticoagulant of choice. I'm sort of showing 4 different sort of members of the family of DOACs: Pradaxa or dabigatran, FDA approved in 2010; rivaroxaban or Xarelto, FDA approved in 2011; and Eliquis or apixaban, FDA approved in 2012. Now, big pharma companies have basically pushed these drugs onto the market with the notion that, unlike warfarin, basically these drugs do not require constant or regular monitoring of the anticoagulant effect. But in practice, at least in acute scenarios, for example, involving on-treatment bleeding complications for the patient, emergency surgery, suspected non-compliance, or for example, when a decision needs to be made to administer a DOAC reversal agent or not, there is a need basically for monitoring, rapid and timely monitoring of the DOAC anticoagulant effect in the blood sample. The problem is that there are no FDA-approved devices right now on the market to monitor anticoagulation therapy with DOACs, and that's basically our first application for us to sort of explore and investigate whether clot shift can can play a role, sort of bridging this gap in clinical need. So, what we did is that we ran a prospective single center pilot clinical study in Cleveland over more than a year to determine if clot shift can ultimately detect anticoagulant effect of DOACs. We recruited 154 participants into a 2-arm study. 50 of these folks were healthy volunteers, healthy donors, no known issues basically with blood coagulation. 104 of them were actually patients, basically in the patient arm of the study, and 49 of them were on rivaroxaban, 47 patients on apixaban. We only ended up basically having 8 patients on dabigatran, which basically tells you already that the DOAC market, at least in the US, is dominated by rivaroxaban and apixaban. Now, we actually published many results from this pilot clinical study in our thrombosis and hemostasis basically manuscript about 4 years ago. Here I'm showing the receiver operating characteristic, or ROC curve, for the clot clot shaped T peak parameter coming basically from the, coming from this study. The measurement of true positive rate on the y-axis versus false positive rate basically on the x-axis. The black dashed line is the non-predictive line. If you somehow fall in this line, you might as well basically flip a coin in order to sort of make your, make your assessment. The area under the curve or AUC parameter basically, corresponds to 0.5, for the non-predictive line. You obviously want to be somewhere basically in the upper left corner of the ROC curve. It turns out that the area under the curve, basically for all 49 patients on rivaroxaban, was 0.83. We actually sort of monitored and tracked a subgroup of these Riva patients, 25 of them, for whom we knew that the blood sample was collected at a time instance corresponding to peak drug concentration in plasma. And again, as expected, the area under the curve or AUC parameter was actually even higher, more than 90 or 0.92, basically for that subgroup of Riva patients. The area under the curve for the 47 patients on apixaban was very similar to Riva, 0.82. The AUC was actually 1 for dabigatran, but again, as I said, we only had 8 patients basically in that particular sub-arm of the group. Now, choosing a T-peak threshold value for this curve just under 9 minutes, the diagnostic sensitivity was found to be 73% for rivaroxaban. It actually went up to more than 90% for the Tmax subgroup of Riva patients. The number was also very similar for apixaban patients at 72%. With AUC of 1, the number was 100% for dabigatran, but again, we only had 8 patients in that group. And the diagnostic specificity or selectivity was 88% across all DOACs. And these numbers and this performance basically ultimately garnered the ClotShip and FDA breakthrough device designation in early 2020 for monitoring DOAC anticoagulation therapy. Next, we also sort of looked at perhaps the utility of the ClotShip assay in monitoring coagulation factor replacement therapy in hemophilia A patients. In fact, in pediatric patients, in this case, on the left-hand side, you see, for example, the the red curve and the green curve. These curves basically correspond to blood samples tested from 2 children with severe hemophilia A, abnormally low or missing coagulation factor 8. As you can see here, for example, for one child, on the green curve, the T-peak or the coagulation time was already about 25 minutes. For the second child, was even worse, basically, about T-peak of 35 minutes. But then 15 minutes after each of these children received, a prophylactic therapy, significant decrease in the ClotShip T-peak parameter, down basically to less than 10 minutes. In fact, here's the paired plot showing basically that for all 14 pediatric patients that we had recruited, the post-therapy reading of the ClotShip basically in every single case was smaller or lower than the pre-therapy reading of the T-peak value. And perhaps more importantly, all the post-therapy ClotShip T-peak values fell basically within a reference range set by 50 healthy children who were also recruited into the study, basically with no known issues with hemophilia or other types of coagulopathy. And now, as I mentioned at the beginning of my talk, basically since since early 2017, so about almost 9 years ago, basically we have tried to commercialize the ClotShip technology, basically as as a handheld, a whole blood-based device suitable for field deployability. Shown here on the left-hand side is the commercial ready version of the ClotShip device, basically sitting on its docking station. On the right-hand side is the productized version of the clot chip sensor cartridge, requiring less than 10 microliters of whole blood sample, basically for sample analysis in a single-use reagent-free type of embodiment. These features basically, we find them to be ideal characteristics for ultimately for pre-hospital use of this device. And again, it turns out that the fact that we are sort of performing blood coagulation monitoring using a fully electronic measurement technique with no presence of mechanical or moving parts ends up conferring basically a big advantage, to the clot chip assay as compared to viscoelastic hemostatic assays that have the presence of moving and mechanical parts. And that advantage comes in the form of a much higher level of resiliency to motion and vibration artifacts. Here shown on the left-hand side is basically measurements by the commercial ready, wearable or portable, I should say, portable handheld commercial ready version of the clot chip device. 4 different replicates of a measurement for one given human whole blood sample. These measurements are conducted by a U.S. Navy medic, basically on the ground. And then here you see the same measurements conducted by the U.S. Navy medic on board a flying MH-60S Nighthawk helicopter for medical evacuation during level flight. What you should sort of see here is that absolutely no presence of vibration or motion artifacts on the clot chip readout curves while basically experiment is being conducted on board the flying helicopter. These curves are as good basically as what can be achieved on the ground. It's very difficult, if not virtually impossible, basically, for this to happen for a viscoelastic hemostatic assay on board a flying aircraft that, again, has to sort of rely, has to rely upon the presence of mechanical and moving parts. Now, where are we going with this? The next aspect of our work is development of the trauma check system as the next generation for clot chip. We envision trauma check to be a multi-channel, portable, handheld diagnostic device for early, rapid and and comprehensive assessment of trauma-induced coagulopathy or TIC. The hallmark of TIC is that you have now simultaneous or concurrent presence of multiple types of hemostatic defects, perhaps arising from coagulation function, platelets, or fibrinolytic system. And the biggest difference between trauma check and clot chip is now is that now we sort of aim to sort of use surface coating of the gold electrodes inside the microfluidic channel with properly selected bioactive reagents in order to sort of confer much higher level of specificity basically in the in the assessment, with the idea that if you can somehow pinpoint the source of the hemostatic defect in a case of TIC where where you can have concomitant presence of multiple scenarios, it can ultimately sort of guide appropriate transfusion interventions in order to basically address the problem, hopefully again at the point of injury or at the point of need in general. We have taken the first step basically toward this using TRAP6 or thrombin receptor activating peptide 6 as a potent platelet activator, and basically use TRAP6 now to surface functionalize basically in this case the surface of the gold floating electrode. We do this by modifying TRAP6 basically via the introduction of a thiol group on the C terminal, and then ultimately basically the thiol group forming a covalent bond with the gold surface at basic pH levels, as shown also basically in this cartoon schematically speaking. Here's a microscopy image of the surface of the gold, confirming the presence of the TRAP6 and the localization of the TRAP6 basically on the gold on the gold surface, with really no presence of TRAP6 on the polymeric substrate. Here you see basically what happens basically in the case of platelet count defects. So in this case, basically we have changed the number of platelets in reconstituted whole blood samples from 200,000 per microliters, basically representing a normal, healthy physiological platelet count, down to 50 to 20 and down to 5,000 per microliters, basically representing severe cases of thrombocytopenia. And again, we can see that basically significant increase in the T-peak parameter, significant decrease in the delta epsilon max parameter as a result of basically a deficits in the platelet count, basically signifying that the TRAP6 coding can basically, provide basically sensitivity and specific. It can provide sensitivity and selectivity, I should say, basically to platelet function. Now, in summary, we have sort of used the DS technique as a monitoring technique to extract important physiologic parameters from whole blood. We do this using the clot chip microsensor based on a three-dimensional capacitive sensing structure that is ultimately capable of extracting a complex whole blood permittivity, using less than 10 microliters of whole blood. We have identified several different readout parameters in the clot chip curve that ultimately provide information or distinct information about coagulation time, platelet status, and basically the fibrinolytic system. And again, these same readout parameters of the clot chip also exhibit basically strong positive correlation to their counterparts of a clinically relevant hemostatic assays such as ROTEM. And we ultimately hope and envision basically that clot chip will have significant potential for point of care assessment of coagulation process in clinical scenarios involving monitoring the anticoagulation effect of DOAC blood thinners as well as in coagulation factor replacement therapy in hemophilia care management. With that, I have to thank you, my research group, my collaborators, and our funding agencies over the past 10 years or so. And again, thank you very much for being here.
Thank you for the fantastic talk, Professor Mohseni. As I wait for a few more questions. It's an exciting technology. Can you measure just red blood cells from blood with your technology, which is needed for hematocrit measurements?
So we have just basically looked into measuring hematocrit as well using using this sensor. Right now, basically for all the experiments that we have done, the hematocrit level is in the normal range. A normal range of 30 to 40%. But we have shown again, not in this presentation, but we have shown that we can sort of estimate the hematocrit level once again, sort of using different parameters of the clot chip readout curve.
Thank you. How does the fluid move in your system? Is it capillary lateral flow assay?
Yeah, so basically this measurement is ultimately a quasi-static measurement. So basically when the measurement is being performed on the blood sample is just sitting ideally within that three-dimensional capacitive sensing area of the sensor. So there is no flow involved basically during the measurement. Some flow is involved as we inject the blood sample into the fluidic channel from the inlet. But ultimately when the actual measurement is happening on the blood sample, it is sitting basically inside the fluidic channel with no flow.
Yeah, I guess my question is, the blood is inside the human, and somehow it has to get to your, reservoir for testing. How does it get there?
Oh yeah. Oh yes. Okay. So if I go back here, for the yes. So for the commercial, for the commercial sort of ready version of the clot chip sensor, it's basically wicking technique. Basically, you would do a finger prick and then kind of hold your finger basically close to this cartridge opening for sample loading. And then basically, the cartridge has been designed by the company in a way that basically the whole wicking process will sort of move the blood sample from the fingertip into the fluidic chamber of the cartridge.
Okay.
For the lab-based measurement, we just simply use the pipette, to inject or to kind of insert or inject a blood sample into the channel from the inlet of the sensor. I had a picture of it. If I just quickly go back, I think here, yeah, basically as shown here, basically a simple micropipette to inject basically the blood sample into the sensor. But again, these are just lab-based measurements in our lab.
Thank you.
Of course.
Thank you for interesting presentation. Is there any strong interference, for example, glucose, that can affect the selectivity of permittivity measurements?
Yeah, I mean, we have not basically looked at how glucose can play a role, or if glucose basically plays a role. We have not looked into that.
Okay. Use of this device compared to your Rotem machine, which is benchtop. In the military, imagine you're testing this in a war environment. What is the purpose? Like if the person cannot coagulate blood, then what happens? They give extra medicine, or what is the purpose of using this in a war fighter, war scenario?
Yes, yeah. So basically, right now, basically the medic kind of has a one size fits all type of approach to transfusion. If whole blood, fresh whole blood is available, basically on the front line at the point of injury, obviously the medic will inject or will transfuse whole blood, and basically there is no need essentially sort of for component therapy. But the role of trauma check comes more in focus, or comes more in the picture if the approach for transfusion therapy will go now toward component therapy, meaning that you will sort of not transfuse fresh whole blood, transfuse, for example, platelets only, or transfuse, plasma or coagulation factors only. But that depends on you knowing what the cause of the hemostatic impairment is. If you know, again, in real time at the point of injury, that the cause of the hemostatic impairment at the time is, for example, platelets, then you will normally just transfuse platelets and not basically fresh whole blood. So again, the role of trauma check, in military comes into picture if the approach will go more toward component therapy, as opposed to just transfusing fresh whole blood. That is very, very difficult to basically store and have fresh whole blood, basically, again, on the battlefield in a far forward setting at the point of injury. What we call role one, basically, in military.
Thank you. One final question. I think this DS measurement is extremely powerful, very interesting. Have you thought about your integrating your technology into a catheter to monitor biofouling or other things?
Yeah, no, and not yet. We sort of thought about basically sort of incorporating the DS technique or the approach into catheters for ECMO patients, but that did not go beyond basically our discussion with the clinician collaborator, because he ended up leaving Cleveland. But that was the only time that we sort of thought about basically sort of embedding this type of sensing method, a sensing methodology into a catheter type scenario.
Well, that's all the questions I have. Thank you for your time, Professor. Exciting talk.
Of course, thank you very much again for your attention. Yeah, have a great day.